Good morning, everybody. My name is Mary Pearson. I'm a CTRS and also a former student from SUNY Portland. So it's really nice to see a whole bunch of familiar faces and names on the chat with us today. So thanks for everybody for coming and spending your day, taking breaks from work. I know that this is not our normal way of having a conference, so thank you for being with me today, and also thank you for bearing with me today because this is definitely my first experience presenting virtually. I was in a couple sessions yesterday and everybody has been a real trooper, and I am excited to be here with you today. So let's jump in. We're going to be talking about pain management in how, as recreation therapists, we can be part of that process. This morning, we're going to be mostly focusing really on foundational knowledge, going back to basics about what pain is, and really focusing on how to assess for it, how to manage it, what to look for. And then we're going to really talk about what our role is in that pain management process. This all came about because I was reading our handy dandy TRJ. For those of you who do not get the TRJ, definitely recommend. Great read, very insightful. Plug for those students, get the TRJ. There was an article in there by Judy Kinney. The article was Recreation Therapists' Knowledge and Attitudes Towards Pain. And in it, she looked at therapists across a spectrum of modalities, across populations. And what she found was that people had little to no pain management training, had very little awareness of what therapeutic recreation could be doing as far as pain management. And so their attitudes were a little skewed. So people had misconceptions about how pain looks in people as we age through the lifespan, and also about sleep and distraction skills. Therapists were confused about how pain can look as far as sleeping too much, sleeping too little. People who are in pain, are they actively engaged in activities? Do they shy away from activities and withdraw? So not great, right? So what we're seeing is also that people who worked in a population with geriatrics, older adults, stated while they see patients with pain, they're not addressing it. It's the other disciplines in the treatment team that are working with pain. So this leads us to kind of question, right, why is this? What deficits do we have in our training that we are not looking at pain in a more critical lens, and we're not addressing it as people who certainly could be? And we know, right, that our attitudes and beliefs, how we feel about our patients and the treatments that we're providing and the interventions we're providing, that directly affects patient outcomes. We've got to believe in what we are giving, right? So eventually what the article drew as a conclusion was that training made the biggest difference in changing scores towards attitudes. So hopefully today, we'll be able to really get some good foundational knowledge with the hope of changing our attitudes and changing how we address pain as practitioners. Art, I really love that you have your child here with us today. I think that's really great. Hello. So let's define some pain. There are two types of pain generally. The first is acute pain. So I'm going to botch pronouncing this, so I apologize, but nociception is your unconscious stimulation of nerves in your periphery, and it sends an unpleasant stimuli to your brain. Pain is the processing of that stimulus in your brain in all of the different areas associated with sensation, emotion, cognition. So it's not just one part of your brain that lights up when you experience pain, right? And we know this, right? The same feeling we do not get the same feeling of pain when we put our hand on a hot stove as when we step on a rock. There's also chronic pain. This is pain that persists for 3 to 6 months or longer. It's estimated that 50 million adults have daily chronic pain. Of those, 19.6 million have high impact chronic pain, meaning that it is affecting all of their activities of daily living, including their ability to have a job, interact with family and friends. And we know that that's kind of our bread and butter in recreation, right? How do we keep people involved when they're experiencing this pain? The other piece that I find really, really insightful for us here is that 25 to 50% of community dwelling adults and 80% of nursing home residents live with chronic pain. So these are patients we're seeing, right? For all of those who work with older adults in the nursing home setting, that's 80% of our patients. That's a lot. So where does pain come from? So pain has lots of different origins. It might be musculoskeletal in origin. It might stem from arthritis, sciatica, lots of compression fractures and back pain. You may also have a neuropathic disorder, right? A lot of our folks who have diabetes, which is on the rise, may have nerve pain, especially in their outer extremities, fingers, toes, fibromyalgia. You also might have idiopathic or psychologically mediated pain. So that can be associated with depression or somatoform disorders where, you know, the people that you're working with are converting their psychological pain into physical manifestations. So people who are having severe anxiety or depression, you might see that as headaches, stomach pain, in some extreme cases, maybe seizures or other really large psychological concerns. So when we look at pain, we also want to address some risk factors here. Big one, poverty, right? A lack of access or ability to pay for care. Comorbidities, medical and psychological, so heart conditions, vision impairment, hearing loss, depression, anxiety. A lack of sleep can be a risk factor for pain. And I'm sure all of us who are parents maybe can attest to that, right? How many of us in the middle of the night have injured ourselves when we go and reach for the crying infant in the crib, right? We also, cognitive impairment is a risk factor for pain, right? If we are having not thinking our best, or we have a cognitive impairment of some variety, maybe dementia, we might not have the insight and judgment for safety awareness. A history of pain, under treatment of acute pain, which is something that the research is showing us is much more prevalent because of our concerns with overprescribing medications right now, particularly opioids. So now we're kind of having a reactive effect where practitioners are not prescribing or not treating acute pain, and it's leading to long-term pain and chronic pain. Other risk factors include a history of substance abuse, smoking, and a self-rated poor quality of life, which makes sense, right? Consequences. So there is a cycle of pain here, right? You're going to see some risk factors that also look like consequences. So depression, anxiety, decreased socialization. If you're having an arthritis flare-up, it's not likely that you are going to want to go and hang out with your peers. Strained relationships and caregiver stress. If you require a lot of assistance from family members because of an acute chronic pain condition, it's going to have stress on those relationships around you. Sleep or appetite disturbance, right? You may not want to eat or sleep if you're in a lot of pain. Or on the flip side, if you're in a lot of pain, you may want to sleep a lot and eat a lot. Impaired ambulation, you're going to be using the healthcare system a whole heck of a lot more. And polypharmacy, you're going to maybe require a lot of different medications that may have interactions with each other that need to be addressed. Okay, so this is where we get to the good stuff, right? Pain is not good. There is a lot of pain happening in our country. We need to start looking at how to manage that more effectively and how we as recreation therapists can start managing that in our interventions. So here's the basic premise. In order to lessen pain, we need to utilize those neurotransmitters, right? They're those handy chemical messengers that jump between neurons in our brain and send messages across our body through the spinal system. So that sounds really heavy, but when we look at both the medication interventions as well as the interventions that we can do, the entire idea is how to boost those positive neurotransmitters and kind of decrease the ones that are signaling pain. So in pain management, we've got 4 big branches. The first of which is your pharmacological interventions. These are very familiar to us to some extent, right? So our first one, Tylenol. Then we've got your NSAIDs, your aspirin, Aleve. Of course, with those types of medications, we have to be careful depending on our populations. Now, obviously, we're not prescribing, but having an awareness that those types of medications may cause bleeding concerns is definitely something that we need to be aware of when we're working with people. The other medications that people may be less familiar with are anticonvulsant medications. So one of the big ones is called gabapentin, and it affects neuropathic pain, so pain related to your nerves, often used in diabetes, often used in chronic nerve pain, such as in the back. Then we also are seeing antidepressants and anti-anxiety medications used. So tricyclics like amitriptyline and SNRIs for neuropathic pain again. So these are your Cymbaltas, your Effexors. Again, we are not prescribing, but having an awareness of what your patients are on can really affect and inform your decisions, right? Having an understanding that with all of these medications, there are side effects, including especially with the anticonvulsant medication, sedation informs how you're going to approach and work with that patient, right? Then opioids, your Oxycontin, your Vicodin, your fentanyl. I know I am putting fentanyl on there. It is a prescribed medication. I know I didn't tell you where I work, but I do work on a senior behavioral health unit. We work with people who are over 55, usually with many comorbidities. And fentanyl is being prescribed frequently for end-of-life pain, palliative care, very, very severe pain type symptoms. And then other pain management techniques, medications, topical lidocaine placed right on the area of pain or near the area of pain. That's the same lidocaine that your dentist would use. And then anybody recognize, you can use your chat function. Anybody recognize that last one? What's that last one? Yes, Botox. Not botulism. Botulism. Hi, Hannah Brown. Nice to see you. So yes, it's Botox. So Botox not only used to make your lips look luscious and gorgeous, but also used to help treat migraines. So interventional procedures. So these are, again, prescribed and facilitated by an MD, but you may have an epidural steroid injection. So there will be a delivery of an anti-inflammatory medication right into that epidural space, not unlike if you were having a child that had an epidural. This is a similar idea. Then we have a facet nerve block or a denervation. So along your spine, right, you have your facet joints, and weaving into these are medial branch nerves. When they do a block, they're putting local anesthesia right into that medial branch, and that's going to have, hopefully, long-term pain help assistance. Then you've got your cryoneuroablation, which is a fairly new pain management technique. It's very cool. This is where there is a cryoprobe. So literally a long probe goes into the area where there is pain, and they freeze the sensory nerves at the source of the pain. So this is, I've seen done for foot pain, right, plantar fasciitis, that kind of thing. Then the last one that I want to touch on that's used fairly often is radiofrequency ablation. So this essentially, it burns the nerve and eliminates the transmission of pain. So lots of different options for pain management. Looking at these, we're going to need to understand when our patients have had these, our residents have had these, that there is, some of these are long lasting and some of these aren't, and having an awareness of looking for how pain is responding, if there's a decrease in pain, if there might be any precautions when we use these procedures, what we need to do. Some of these take some time to work. You may need to be aware that patients can't jump right back into a rec therapy program after some of these have been done. Okay, so then we've got some restorative therapies. These are going to look much more familiar to us. Therapeutic exercise, right? Keeping moving, keeping involved, often under. So we can touch very briefly on this, but I will say in the course of my research, which I will admit was very medically based because I am in a hospital setting here, the use of recreation therapy, I did not find recreation therapy, therapeutic recreation, or any other such term in any of my research at this point, but there were like nods to us, including therapeutic exercise. Then we've got our transcutaneous electric nerve stimulation. Some of us may have these at home. These are your TENS units, right? You put the electrodes on the area of pain. It is supposed to help with eliminating some of that pain. However, there's very limited evidence that this is actually a useful procedure, but research is still ongoing. I know a lot of people who find it very effective for them. Then massage therapy, good old hot and cold, part of, right, RICE, rest, ice, elevation, compression. Therapeutic ultrasound, kind of an up-and-coming idea where they are using ultrasound on the areas of pain and seeing some evidence, not a whole heck of a lot, that it is helping in the elimination of pain. And then very old school is bracing, right? Where the affected area is either wrapped in an ACE bandage or in a sling or in a true brace. There is some conversation in the community right now about bracing. It's kind of been from my understanding, a long do we, don't we, right? Because when you brace a limb, then the muscles atrophy around it. And is that really beneficial? Jury's still kind of out. So here, and then our next branch here is our behavioral health approaches. So cognitive behavioral therapy, obviously you need specialized training to deliver CBT, but it focuses on shifting cognitions, improving pain and coping skills. Here is our hot button here, this next one down, mindfulness-based stress reduction. MBSR seems to be the flavor of the last couple of years as far as being like the big thing in integrative medicine, right? So this is in improving an awareness and acceptance of physical and psychological wellness through body awareness. It is a very strong, meditatively rich program with some interesting research that says that it is pretty effective in eliminating pain long term, as long as the practice is maintained. This does tend to want a certification when you are doing specifically mindfulness-based stress reduction. However, it sounds like a lot of what we do as recreation therapists. We do relaxation, we do mindfulness, we will do guided imagery, right? So the leap to MBSR is not very far. And then our last tab here is self-regulatory psychophysiological approaches. This is your biofeedback, right, where you are hooked up to an EKG, your blood pressure, heart rate, and provided feedback as you go through relaxation training. And hypnotherapy, right, where you are put under hypnosis by a certified practitioner as well, has some pretty substantial efficacy, which is pretty interesting to me. Okay. Last one here are complementary and integrative health systems, acupuncture, massage, yoga, Tai Chi, and I really did want to highlight here spirituality as part of that. That was really looked upon. I think sometimes as TR professionals, and I'm mostly speaking for myself here, but I have colleagues who have shared and expressed this idea, is that sometimes we have a hard time integrating spirituality into working with our patients, but there are significant studies that look at spirituality and having a practice as a patient that says that helps to eliminate pain. So we need to look at how we can create interventions that incorporate spirituality in really meaningful ways. So those are kind of the big 4 areas of pain management. I want to dive a little bit more into why before we start looking really at us specifically, I want to dive into why people don't look at anything other than, for the most part, the medications when we look at pain management. Part of it, right, this is going to sound very familiar to us. A lot of reasons why our patients tell us they're not participating in leisure skills or leisure areas anyway, or any other kind of treatment. They tell us transportation is an issue, right? Oftentimes people don't have a car, they can't walk to their therapies. Scheduling around busy lives. The cost is certainly prohibitive at times. A belief that the medications are more effective, right? I'm going to take my medication, it's going to make me better. And then I can move on, right? There's a burden that is associated sometimes with non-pharmacological treatment modalities. You need to go to your massage therapy appointment every week. You need to commit to that, right? And then there is also a perceived stress in, I'm going to have to think about this every week, as opposed to I take a pill every morning and I'm magically fixed, right? And a lack of support, both from the healthcare side and from their personal network. But the thing that I find really striking is that one of the most significant barriers here was that there was no insight into the fact that anything other than medications and surgical procedures were available in pain management. Many folks during the research stated they didn't know they had any other options. And once they were told that they had other options, they didn't know why that would be considered beneficial for them, or why they would even want to consider that as opposed to pharmacological intervention. So very interesting here, right? We're looking at a lot of barriers we see fairly often. But the big one here, I think we see this as recreation therapists a lot. What are you? Who are you? What do you do? Right? So I think this opens up, while these are really serious barriers, I think this gives us an opening of saying, hey, I'm a recreation therapist. This is what I can do for you. This is what we can work together on. And we can figure out some of these other pieces. So the next piece here is that we're going to spend a couple of moments kind of looking at the different scales and different ways to assess for pain, right? Now at this point, we know what pain is, we know what kind of interventions we use, but how do we know that someone's in pain and that we're going to need to use an intervention? So, of course, you can see here, the first one is your very simple numerical rating scale. So we've got 0, no pain at all, and 10 being the worst pain you've ever had in your entire life. One of the pros to this, right, it's pretty straightforward. It's a numerical scale. However, it's self-rating. So when patients tell you that, oh my gosh, I have incredible amounts of pain, it's a 9, for a headache, and they are then turning around and, playing catch with their buddy, you may scratch your head and say one of these things is not like the other. Or opposed to your patient who has moderate to end stage dementia, who is saying verbally they have no pain, but you can notice that they're wiggling in their seat and they're grimacing. This may not be the best scale for those types of situations. This is one of my favorites, only because it makes me chuckle every time I see it. These faces are fantastic. I don't know who drew them, but they deserve some kind of award in my book. So these are your Wong-Baker faces. It's just a simple pain rating scale, numerical, just like the other one, but now we have a visual to add to that. So you can ask your patients what face, most looks like how you're feeling inside. Or you can kind of say, if your patient is nonverbal, they're kind of making a 6-ish face, their eyes are kind of drawn, their mouth is turned down, maybe they have a little bit of pain. This scale is often what we see when we go to the emergency room. It works pretty well for children, right? I'm sure many of us have seen this scale. But again, it's mostly self-rating. So you're going to have that bias there of, are we totally sure that our patients are telling us exactly what I'm seeing? This pain scale does not give me joy. It is busy. It is hard to read. It is complicated, but it is one that's used sometimes frequently. So we've got this universal pain assessments tool where we've now combined the simple 1 to 10 rating scale with the Wong-Baker facial scale and a word prompt at the bottom here. So you've got some activity tolerance where there's no pain, interferes with concentration, right? We're now getting a lot more into it, much more detail here. And then this will often have multiple languages at the bottom, which I think it's a beautiful thing, right? We need to be able to communicate with our patients no matter what language they speak. I will say that I do find this one to be a bit busy. I do work with people with dementia and other cognitive impairments. So for me, this is too much. Our patients have a really hard time attending to this in a meaningful way. So this is called the FLACC. This is one of my favorite assessments. It is an observational scale. It's the face, legs, activity, cry, and consolability scale. And this you take a quick scan of your patient, you do a pretty good look, and you say, okay, in their face, do they have any particular expression? Are they smiling? Are they grimacing? And then you look at their legs, right? Normally positioned. Are they kicking and restless? All the way down, can they be reassured? Or are they completely difficult to console? And the higher the number, the more pain that is likely in the patient, right? So this definitely helps. The reason that I like this assessment is that it not only helps to identify the fact that a patient is in pain, but also, at least to some degree, how much pain the patient is in. Oftentimes, of our own observation as practitioners, we can say, yes, I believe that this patient is in pain, but we have a difficult time rating just how much pain our patients are in specifically. So I do like that this carries both of those pieces in it. And our last one here is the Pain Assessment in Advanced Dementia scale. Very similar to the FLACC. It looks at breathing. Our patients can have lots of different respirations, lots of different vocalizations, different facial expressions. Are they sad, frightened? Are they smiling? Our body language, right? I'm sure we can all imagine probably one patient who refuses to tell us that they are uncomfortable or in pain, but they are sitting at the back of the group and their arms are crossed. They're sitting there maybe fidgeting and they can't pay attention. And go, are they ignoring me? Are they upset about something or are they in pain? I do like this scale because it does help to kind of focus that attention a little bit to find more valuable information. And of course, there's nothing to say with these observational scales that you can't approach your patients and say, hey, I'm noticing you're kind of fidgeting or you're kind of really tense. You're kind of making some moans. What's going on? But for those patients who maybe have advanced dementia or are otherwise nonverbal for other reasons, these are nice ways to really look and focus. Okay, here we are. One of the pieces from the Kinney article talked a lot about the Joint Commission standards, specifically good old Norma Stumbo, right? We all know Norma Stumbo, our writer of many books, has asked that each of us be familiar with our Joint Commission standards and have an understanding and awareness But just because we know it's good for us doesn't mean we always do it, right? So Joint Commission standards, they recently came out with, well, a while ago, they came out with pain standards specific, and not too long ago, they updated those pain standards. And just having awareness of the fact that while we are not mentioned by name, there is certainly a home for us there can be very important when we go and advocate for ourselves in these settings. So for pain specifically here in hospitals, they need to provide non-pharmacological pain treatment. Has to happen. Now, that can be what it's, gotta love the Joint Commission. They're always very vague, right? But it can be whatever the hospital wants, but they have to provide it. They need to promote the fact that they have it so patients are aware of it. And they need to know where to send their patients to get different modalities that are not being offered specifically at the hospital. Which is important for us to know, right? Because we can say, hey, I am a non-pharmacological modality. You can advertise and promote me. And hey, also maybe give me a pay raise because now I'm going to provide the service for you. Or hire me because I can provide the service for you. Hospitals also need to develop a pain treatment plan that is evidence-based and person-centered. Well, if that doesn't scream therapeutic recreation, I don't know. We make a perfect match into that. Absolutely. Now, that does take the onus on you as the recreation therapist, maybe to go to your supervisor and say, hey, look, here's the documentation. This is what I can do. Then in behavioral health settings specifically, your organizations need to screen all individuals to determine who needs a more in-depth pain assessment and plan. They need to provide strategies to treat pain. However, they don't have to include non-pharmacological approaches. So I pulled that language that may, right? So strategies used to treat pain may include pharmacological and non-pharmacologic approaches. That's right from the Joint Commission. So it's very vague. It doesn't have to be anything other than medications, but we all know that it definitely should be because the way to really treat pain is through a full-bodied approach. So let's talk a little bit here about our interventions. I have been yapping at you now for 30 minutes, so I'm going to run through these, and then I want us to talk a little bit about other interventions that we can use. So here we go. Here are the big ones that are evidence-based in our practice. Relaxation. We do this all the time, right? In my groups, just the other day, we did relaxation A to Z, and we then chose 3 or 4 to practice as a group together. We do guided imagery. We will read scripts. We will help patients to pick their own guided images to follow, right? Meditation sometimes, coping skills group, distraction skills, and of course, leisure education. The other day, I did a whole group on what is flow and how to find it, right? And how to use flow as a coping skill, right? So work with me here. What other interventions do we use as recreation therapists that may be instrumental in pain management? And while you think, I'm going to take a sip of water.
Hi, Kelly. I would say sensory stimulation.
Okay. Oh, Jason says acupuncture. We've got music therapy, yoga, hand massage. Absolutely. I love the idea of sensory stimulation. What kind of sensory activities are you using? Gentle stretching with aromatherapy, great. Hand massage, herbal tea, love that. right? What a great sensory experience, very relaxing. Animatronic pet therapy, Anne-Marie, that is very cool. Play-Doh. Has anybody ever put some really cool essential oils in your Play-Doh? The 2-for-1. Horticulture. Yes. I'm very jealous, Savannah. We are not allowed to have a dog on my campus. I think that's wonderful. Yes, pet therapy, animal-assisted therapy. Aquatics. Michaela, what population do you work with? You can talk to me, I don't bite. I know that the chat is probably easier, but it's okay to say it out loud too. Adults with developmental disabilities, scenic rides. Wonderful. Yes, and it sounds like many of these things, you know, are still activities that we can be doing in the time of Corona, which is really wonderful. One of the things that I will say is definitely a challenge right now, as I'm sure we've all talked about and discussed, is that in the time of coronavirus, it's very difficult to make sure that we can do things that are really effective. And it's definitely been a challenge. And I think we're all doing as best as we can with what we've got. It sounds like the interventions that you all are sharing with us are fantastic ideas, right? I know at my facility right now, we are a community-based program for the most part, right? We have a milieu, a day room where we are used to having our patients sit and interact and, you know, pivoting to much more socially distanced activities without any volunteers in the building, right? Because we can't have any visitation. It's been quite a challenge, but many of these things can be brought door to door, right? Therapeutic use of humor. Dan, very nice, yes. Hey, why was the vampire not interested in Taylor Swift? She had bad blood. Sorry, couldn't resist. Okay. So, what's next here for us? Here's the deal, right? On the facility level, we need to be advocating. We need to be looking at effective treatment plans that include us as part of the pain management plan. As you have all just evidenced, there are lots of things that we could be doing. But as I mentioned earlier, we're not seeing us in the data. We're not seeing us in the research as modalities that are being looked at as effective treatments for pain management. And we know that we can do that, but we need to be advocates for ourselves and we need to start really pushing to be included at the table, which includes at the national level. So the next step for pain management, and it's happening now from facility and regionally, but there are no national clinical practice guidelines for pain management. And there are certainly not those practice guidelines for specific diagnoses and patient populations, which means just like when we have facility-specific protocols as opposed to protocols across population and diagnosis, we're not having the best level of care, right? Because it's not uniform, right? We're not all using the same best practices, the same evidence-based materials and resources. And that's what we're seeing on a national level across a lot of these treatment modalities. So the next step on the large scale is to have protocols. Now, I'm saying that, but we also have to understand that our patients are people and we need to be able to individualize. Some of the research that I started looking at really talked about is that, totally lost my train of thought. It's gone. So we're looking at these things. We need to have guidelines. We need to be part of the table and we need to individualize. People are getting nervous about prescribing opioids to patients who really, that's where I was going. Providers are getting scared about providing opioids to patients and prescribing opioids to patients because we're in an opioid epidemic. But there are certainly patients who are absolutely appropriate for long-term use of opioids with specific treatment plans and measures in place to monitor and make sure that they are safe to do so. And that may really be the right treatment course for that individual patient. So we have to work on a larger protocol with the understanding that patients are individuals and we need to be flexible for them. But nobody's going to hear us unless we're at the table, right? That's the piece that's really, really important. We need to get ourselves at the table to talk about how we are part of the bigger pain management team. Yes, Beth. Yes, we need to become licensed and recognized. Yes. So that's what's next for us. I do know that I talked very quickly, but I would like to open things up for questions and final thoughts. I do tend to prefer that people talk during my sessions, so I probably cut myself a little bit short in the hopes that we could have a little bit of a discussion. Steve Schaff, nice to see you too, sir. Hello.
Hi, Mary. Good to see you as well.
So Anne-Marie, you're on the care plan team. That's fantastic. I'm glad that your doctor is involved. But yes, it can be very difficult to get the staff on board when we say, hey, look, I think this patient is in pain. I think we need to do something. Sometimes, you know, you feel like you're shouting at a wall. But thank you for fighting the good fight and continuing to speak up for your patients. So I work with, yes.
I was going to ask you a quick question. So gabapentin was on the list of pain medications. In the SUD field currently, doctors are actually moving away from prescribing gabapentin because of the abuse potential. I'm just wondering how that affects some of the other populations that are served, you know, in terms of the addictive nature of that substance and whether other people are seeing a decline in its use. So it's, I guess, a question to you and to the group. Sorry.
No, that's perfect. So yes, I'm sure you have the expertise, right? In SUD populations, substance use disorder populations, they are straying away from that. Gabapentin is certainly something that we're looking at as having an addictive quality. I work specifically with geriatric adults, so we're not necessarily seeing as a long-term use. But we are being very kind of aware of ordering it and looking at other things, maybe Lyrica. Again, I'm not a provider, but our doc does often talk about how do we avoid those types of things. What about other folks? Are other people seeing gabapentin being used less frequently? Yes, so writing a plan down for your patients is helpful, right? Anytime we can put it on paper is definitely important. Yeah, absolutely, Denise. We are often the people on the front lines, right? So when we come to treatment team, we're going to be asked what we're seeing. That's a good point, right? We are often the people. I also would find we are often the people that patients disclose to, right? So patients will not tell the nurse that they're in an incredible amount of pain sometimes, but they will tell me, hey, I'm having a crazy headache today, but I didn't want to tell the nurse because I don't want them to drug me up. Well, then we are the facilitators between those two pieces, right? Yes, I understand you have a headache. That must be really uncomfortable. Let's talk about what things we can do, right? That's kind of our role sometimes. So someone is annotating the field here, so I apologize for the really cute scribbles. This is my first time with this technology, so go to town. Up. Yes. Can you all see what people are writing on the screen? I'm not entirely. Yes. Okay. Strange times. So does anybody else have any questions? Any other final thoughts or feelings? I hope that I saw all of the questions that people were sent to me. Oh, hi, Kristen. I'm sorry. So the question here is, are you calling your program pain management or the intervention it's based on? Have you had success getting a TR specific goal in treatment plans directly to pain management? So when we, as the treatment team, meet, we will just identify that they have pain as part of their treatment plan. And then we look at specific interventions for each of the members on the team. So in our treatment plans, yes, we do have a recreation goal, an intervention for our people. Depending on the patient, sometimes our intervention is only to assess for pain and then report to nursing, because our patients, some of them are not able to follow one-step commands or ambulate or verbalize sometimes. Other patients, we have them identify coping skills for pain management, and we can work with them on their recreation interests to come up with a discharge plan for their pain as part of our recreation therapy practice with them. I hope that helps, Kristen. So I have worked in therapeutic recreation for about 5 years. My favorite intervention of all time that's a good question. One of the things that I really have loved recently is we have been doing an exorbitant amount of paint pouring at my facility. We have been paint pouring over everything. And we recently have started talking about paint pouring as a metaphor. So when you put a whole bunch of different colors into your cup and we identify, okay, so red, what does red represent in your life, right? So red could be, you know, the angry feelings I have towards a loved one or whatever. And we talk about when you put all of those things in the cup, eventually your cup's going to run over, right? And sometimes it comes out turning out beautifully and you mix all of those pieces together and it's a great thing. And sometimes it turns out looking brown. And what does that mean? And then we kind of look at it further. Often that might be a group that I co-treat with one of our social workers on. So Teresa asked, are CTRS not thought of during pain management because we don't have licensure or because there is a lack of research on how rec therapy treats pain management? You know, it's probably a twofold path there, right? That's it, probably a compounding issue. But I will say I did a lot of reading for this session and we were not really talked about as a part of the pain management picture. That is not to say that the interventions that we do were not discussed, right? Relaxation, guided imagery, meditation were all certainly discussed, but not as being something that we as recreation therapists provide. Meanwhile, OT, PT, speech were all included in that dialogue. And Anna asked, do you have a mindfulness-based stress reduction certification or one that you would suggest? I am looking into getting an MBSR certification right now. I am absolutely not doing it, and I'm not telling anyone that I am doing it, but I am looking at it. Mass General is considered, to my knowledge, like the big one right now. It is a lengthy process through them to get certified in mindfulness-based stress reduction, which is a big mouthful, by the way. It includes you starting the process of taking a course for yourself, and then you can move on to taking courses for working with other people in group settings. So be prepared. It's a lengthy certification, but from colleagues of mine who have it, they use it regularly and they find it beneficial. So, sorry. Lots of good questions. Wondering if you vary how often pain management programs are offered, as some people may need more than one per week. Second question for whoever discussed the hand massage, is there a training for that? How to do or how to do it? So as far as how often pain management programs are offered, it's certainly not once a week for us. It's individualized. So we have 17 patients on our unit. Of those, it probably is pretty reflective of that 80% that I talked about earlier. So we're doing pain groups, individual pain fairly regularly. I will say one of our biggest pain management programs is probably a coping skill group, which we also kind of talk about coping skills for other concerns as well in that group. And anybody, hand massage? Is there a training for hand massage that you've done? Where did you learn your hand massage technique? Perfect. So some of us can find, there are some great hand massage tutorials out there. An awareness, of course, talk to your other colleagues about any concerns that you might have about patients as far as being appropriate for hand massage. Same thing with all these other interventions, right? Aromatherapy, make sure that you don't have any sensitivities in the room, et cetera, et cetera. Yep, there are certainly printable sheets that you can use for those types of things as well. Okay, folks. Anything else that people, thoughts, questions, comments, concerns, feelings, opinions about pain? All right, I'm going to pass it back over to our lovely host. Thanks,
Okay,
everybody.
I'm not sure I qualify as lovely, but thank you, Mary.
Oh, I didn't. It's you. I thought it was a student.
Yeah, I thought you'd change it up with that piece of information. So thank you very much, Mary's fantastic presentation. I just want to let people know a quick update for the keynote speech this afternoon. We're actually going to be streaming it to all 4 rooms simultaneously just because of the capacity caps on each individual room. So if you want to take a break and log out, that's fine. But if you could return to this room after lunch for the keynote, that would be fantastic. All right. So it will be streamed in all 4 rooms. So it doesn't overly matter which one you go into, but we're just trying to spread people out a little bit so that it works better for everyone. All right. Thanks, everyone. Have a great day.
Yes. What time is
Have a
it?
great day.
No.
Keynote is at 12:30.
Okay.
All right. We'll
All right, thanks.
factor in a few technical challenges, but it's scheduled for 12:30.
Okay, great.
Yeah.
Thank
What
you.
number is this room? Jason, what number is this room we're in now?
I believe I'm in number 3.
Okay,
2, sorry.
It's 2.
2, yeah.
thank you.
Awesome.
Once again, everyone, have a great rest of the conference.
Thanks, Mary Kelly.